Death, for many, is something to be feared, while for others, it's simply a part of life. But regardless of how we perceive it, it's something inevitable. More than 50 million people die every year from natural causes or different medical conditions. And the COVID-19 pandemic has pushed the numbers even further. It's estimated that 2020 ended with the deaths of nearly 60 million people. Philosophers and doctors have studied the process of dying for centuries. And perhaps the discipline that has best understood this is palliative care. According to the World Health Organization, palliative care is a crucial part of integrated, people-centered health services, relieving serious health-related suffering, be it physical, psychological, social, or spiritual. And the agency says it's a global ethical responsibility. But is this ethical responsibility being observed? Are health services worldwide providing patients and their families with the right care and services? We'll put that to the chair of the board of directors of the International Association for Hospice and Palliative Care. Dr. Lukas Radbruch talks to Al Jazeera. Dr. Lukas Radbruch, chair of the board of directors of the International Association for Hospice and Palliative Care, thank you for talking to Al Jazeera.
Thank you for having me.
Lukas, let me ask you first, palliative care is not just a type of medical care for patients living with a serious illness. It's also a philosophy of care. So I want to ask you, what is that overall philosophy?
Well, first of all, it's really patient-oriented. So it's not only strict guidelines on how to treat symptoms, but it's also about asking people what they really want. Because, you know, there's a broad range of priorities that patients may have. Some of them cling to life and may want to prolong life as much as possible. Others possibly, well, you know, I just talked to a patient on our palliative care ward who said that she's actually waiting to die, and the sooner the better, because she says this is, in spite of all the palliative care she's getting, she's not going to be well again, and why not end this rather sooner than later? So accepting that and not doing any life-prolonging treatment, giving her good symptom relief, not hastening death on the other side, all that's part of the program. It's also a philosophy about a change from deficits to resources. You know, in medicine, usually we look at things that do not work, organs that fail, symptoms that are there, suffering that is abundant. And in palliative care, we also look at resources, at the caregivers that are still there, at the things that patients still can do, at the family that supports them, at all these things that give the patient strength and meaning in spite of their sometimes really worrying situation. So I think that are the two main differences. And I think that in consequence also necessitates a lot of different things. For example, we talk a lot to patients. We use often really very little medicines, very little technique, but we use a lot of communication, a lot of teamwork, and a lot of discussions with patients and families.
You know, you mentioned teamwork, and since palliative care focuses on so much more than just physical suffering, I've read that oftentimes, or if not in most cases, that there is an interdisciplinary team of physicians that is involved in palliative care. Could you expand on that? What type of team are we talking about? What kind of specialists are we talking about?
So in a good setting, when you really have what you need, then a palliative care team would include not only physicians and, if possible, from different disciplines. So in my team here in Germany, in a high-resource setting, what we have are really physicians working in our team who come from general medicine, from family medicine, from internal medicine, neurology, anesthesiology, so from all fields of medicine. But we also have specialist nurses who have special palliative care training, who have special knowledge in wound dressings, for example. We do have spiritual caregivers. We do have social workers and psychologists, all with special training in palliative care, physiotherapists, ergotherapists. So if we have the team meeting and people are sitting there discussing patients' cases, then it's sometimes 15 people around the table. Mind you, that is in a high resource setting in a tertiary cancer center. In other places, you would probably have only a physician and a nurse, or maybe even only some nurses and some volunteers. But still, it's so important that you have more than one person that, for example, as a healthcare professional, I am able to discuss the way I see the patient, the way I see the needs he has with somebody else, reflect on that, and then discuss whether I really have, whether I'm not blind, whether I don't have a blind spot on something, whether I really have seen everything that's important for the patient. So it must not be the complete team with 15 people, but at least not working on your own is very helpful. In a lot of settings in the world, you don't have that. There's a lot of places, especially in developing countries, where there is one community nurse working on herself. And even then, we would think that having an experienced palliative care service nearby where she can phone in and ask when there are problems is of the utmost importance.
Dr. Radbruch, there does seem to be a lot of confusion when it comes to palliative care. What is the difference between palliative care and hospice care? Could you explain the difference between the two?
Well, it depends a little bit on where you are, for example. So in the US, for example, palliative care quite often is delivered by hospice programs, which are mostly outpatient services or home care services. In the UK, the hospice would be a freestanding building, not affixed to a hospital, where there are specialist nurses and physicians and other caregivers. And in Germany, hospice would be rather end-of-life care by volunteers and nurses, and palliative care would be done by a much larger multidisciplinary team. In general, there's a lot of overlap. And if you want to simplify it, then I could say that palliative care sort of brings the hospice idea of accompanying dying and severely ill patients into the field of medicine, whereas palliative care whereas hospice brings the palliative care knowledge into the general community.
Can palliative care also be given along with curative treatment for patients?
Yeah, some time ago, there was this feeling that palliative care only starts once the patient has been diagnosed as incurable. This, cancer treatment has failed and the patient will certainly deteriorate and finally die, and then palliative care may come in. And we still have quite often this as a kind of barrier that other physicians tell me, this is not a patient for you, we still do chemotherapy. But actually, it's quite important that palliative care is started much earlier. There's this slogan of early integration of palliative care, meaning that it can already start with curative treatment at the same time. And we know that then palliative care will not shorten life, as many fear. When you don't do things in palliative care, this is the feeling we sometimes encounter. But there is good research showing that quite often patients live longer when they receive palliative care early on, even in parallel to curative treatment, because sometimes the treatment is more aggressive than the disease. And then if palliative care comes in and you really discuss with patients what they need, what they want, what is good for them, sometimes aggressive treatments may be left out or may be delayed, and then patients may live even longer, in addition to having better quality of life and less suffering.
You talked about that feeling of fear that so many patients encounter. Obviously, many people around the world are fearful of death and dying. Is the way that a patient perceives death or their perception of the process of dying linked to the type of palliative care that they might receive? And I'm not just talking about for the person dying. I'm also asking about those who are around the patient, other caregivers, perhaps members of the family. Is that taken into account when palliative care is given?
Definitely, because we do have large cultural influences in the way that palliative care, but all kinds of healthcare are received by patients, by their families, and by their communities. So quite often in some cultural settings, you would not explicitly talk about prognosis with the patient. You would probably discuss treatment decisions with the family and not only with the patient, because if they are not involved, then the patient will not accept treatment options. You will sometimes pursue chemotherapy, even though many of the treating physicians know that it's futile, just because you know that patient and family will not accept not getting it or stopping it. Having said that, we know that if you do good, sensible palliative care and if you have communication skills, then quite often you can discuss, even in these cultural settings, with the patient and with their families, that this is not a good way to pursue, that it may be much better to focus on symptom control and not on prolongation of life, which often is futile, that it's much better to spend the resources on palliative care and not on some kind of radio or chemotherapy that does not work. And then patients will be very accepting of that. What we do quite often is that we use volunteers from the community to help the professional caregivers, because the volunteers from the community quite often know how to approach patients, and the barriers are much lower for the volunteers than for us.
What are some of the more significant cultural and social barriers that palliative care health givers encounter?
Well, one thing is that in Western societies, you do have the concept of autonomy, of self-determination, which is really paramount in many people. So losing control is something that is absolutely terrifying for them. Needing care from other people, not being able to care for yourself, is something that they detest. And we even have patients asking for assisted suicide or other life-ending measures because they can't bear losing control. And you have long discussions how to find meaningful sense of life in a situation where you need physical care for yourself. In other societies, that is quite often much less prominent. In African, Asian societies, you have much more community spirit, where patients do not have to have that high degree of autonomy. In contrast, in some settings, proverbial the Mediterranean setting or the Middle East setting, where you do have much less acceptance of an open prognosis. If it's a life-threatening, life-limiting disease, then patients and families will quite often not accept that. They will not accept stopping curative treatment trials. That sometimes they say it's a religious issue, but actually neither Islam nor any other major religion say that palliative care is not allowed, say that curative treatment must be pursued. So in our experience, it's much more often a cultural issue than a religious one.
You know, you just mentioned assisted suicide. I want to ask you, as assisted dying laws are passed in more parts of the world, in more countries around the world, does that create more difficulties for those like yourself who are trying to expand palliative care initiatives around the world?
Yes and no. So one thing is that if a country discusses assisted suicide, quite often this is linked to discussion on hospice and palliative care. And quite often the arguments are that everybody agrees that hospice and palliative care has to be expanded in the country. But what we see in real life then in the countries that have allowed assisted suicide or even euthanasia is that there is a tendency, a slow change in society. So what happens is that this kind of assisted dying becomes more accepted. And in contrast, people start asking, why should you even try palliative care? You know, if the easy way out is just letting the patient die. And sometimes we also see that there is a slow increasing pressure on patients that this may be the option that they should pursue instead of sticking on and maybe using palliative care. So what we see, what we are afraid of is rather the change in society than the immediate pressure on individual patients.
You know, Dr. Radbruch, one of the things I've encountered most when reading about palliative care, I come across physicians who say that it's really expanded their understanding, and that when it comes to palliative care, it's more about understanding the patient or the person they're treating rather than treating the disease. From your perspective, do you believe that health systems, by and large, around the world are lacking in compassion?
That is a really difficult question. So I think the healthcare systems actually do lack in compassion because if you look at the philosophy behind healthcare systems, quite often it has to be utilitarian. So make the most with the budget you have. And that often means that it's not the optimal treatment that patients receive, but rather the one that the society can afford, the healthcare system can afford. Having said that, I think that most of the healthcare professionals really try to be compassionate. There are the few bad apples, but by and large, I think everybody really tries to help patients. That may not always be real compassionate care because many healthcare professionals have not really learned to listen to patients, to communicate well with patients. That is something we start teaching students for a few years now, and we notice how different that is to the rest of medicine. We do have guidelines on palliative care, on symptom control, for example, but we always say that it's more important to listen to the patient than to read the guideline. And that also is not usual in medicine. Medicine in most countries goes by guidelines, and guidelines become more important than the individual patient setting. So by and large, I would say that the systems lack in compassion, even though the professionals in it try to keep it up.
So with that in mind, how important is training in palliative care to the development of a physician?
I think it's paramount that at least some basic knowledge is really taught to every medical student, every nursing student, and probably every other healthcare professional in the making. And that's pretty basic.
What is the next step in ensuring that more people around the world actually have access to palliative care?
That's always the problem on the policy level, is that implementation is always a big issue. And once you manage to get something through on an international association organization like the World Health Organization, that really is something, but it takes a long time till it trickles down to the country level. So actually, in the last decade, we have seen the World Health Organization and the International Narcotics Control Board and the United Nations Office of Drug Control, all of them working on ensuring balance, making sure that really opioids are available for palliative care where they are needed. They have been highlighting the needs. They have been put out guidance with either concrete guidelines or policy papers. There has been a World Health Assembly resolution in 2014 stating the need for palliative care with the 4 pillars that I just listed. And still, so many countries haven't done that. We do notice that some countries really use the guidance by World Health Organization, and the health minister gets interested, they start thinking about this, they set up services. There are some really good examples of public-private partnerships, for example, in Malaysia, where the government pays for the staff if the hospice NGO manages to find a place for it. So if they say, we got this place here, we got this house, then the government will pay for staff. Something like that, where you combine forces. All this very encouraging examples, but still it's a long way from the guideline of the international organization to the national government level, and then even down to the service provider level. And quite often then, after a few years of implementation work, advocacy work by local pioneers, you will have the first service in the capital of the country. But then again, this will not help people in the rural areas who are not even able to access any physician and will not be able to access palliative care at all.
I mean, you talk about it being a long road, and the WHO also says that each year an estimated 40 million people are in need of palliative care, 78% of whom live in low and middle income countries. Worldwide, only about 14% of people who need palliative care currently receive it. What kind of barriers need to be overcome significantly and immediately in order to better address the needs for palliative care? And also, what kind of costs are we talking about? And when I talk about costs, also, are insurance companies on board? I mean, is the insurance system in the healthcare systems in various countries on board with palliative care?
So the main barriers are mostly on the national level. So as I said before, there's lack of training of physicians. So right now, physicians are not prescribing the medicines such as morphine that are needed for these patients. Because they don't prescribe them, the government sees no need to import more of these medicines. So the medicines are not available in the country. Quite often there's not a budget because the countries are struggling to meet other healthcare needs. The budgets are restricted and they say they can't spend money on palliative care. And there's often a lack of policy, so physicians do not even know that this is something they should know about. Actually, providing an essential package for palliative care is not that difficult. There was a commission from the medical journal, The Lancet, which described such an essential package, saying that it's about 20 medicines and a few other things like wheelchairs, which you would need. And the costs of that essential package, equipment, medicines, and staff, isn't actually that high. You can calculate that for a low-income country, for a middle-income country, and for a high-income country, and you will find that all these settings would probably be able to afford that. I was a bit astonished when we produced that report because we thought that in low-income countries, it really would be too expensive, but because the staff costs are so low in that setting, they could actually, even in that setting, afford it. It would be only a minor part of their healthcare budget if you would calculate it per capita. And the overall costs of palliative care would not be that great. And it would provide a benefit because, for example, when you relieve suffering, when a patient is not in agony anymore, is not crying out for pain the whole day, does not need a caregiver and a family member as a caregiver by his side for the whole day, then, for example, the family caregiver can go out and back to work again and can earn some family income again. So palliative care does actually also relieve some of the burden on society that is taken up by informal caregivers by the cost that they accrue. We found in some stages and in some specific settings, for example, for children, that the costs are really so low that you probably would get that together quite easily. And the problem then is not costs, but rather provide training and disseminate the knowledge and the medicines once you have them. So, as I said, I think it's a combined problem of lack of training, lack of awareness, lack of access to medicines, and you would have to tackle all of those at the same time in order to start giving good palliative care.
My final question, Dr. Radbruch, how much has the COVID-19 pandemic been a disruption to palliative care around the world?
It varies depending on country and setting. So in some countries, it has been a major disruption. Patients have not accessed palliative care because they have been isolated in their nursing homes, for example, or at home. And they've been afraid to go to a hospital, even if it's a palliative care unit. Volunteer services have been stopped because of the infection danger. In other countries, additional resources have been required for palliative care because patients were not able to access intensive care, and you would give them at least some good symptom management for the relief of breathlessness, for example. So we see all kinds, but it certainly is a major drain on the healthcare resources, at least in the weaker economic settings. And the danger is that not only right now, but also in the long run, this will weaken palliative care considerably because resources are going in another way right now, even though we know that it's even more needed right now than it was before the pandemic. We are right now preparing, on one hand, the WHO has already something about palliative care in emergencies, in humanitarian emergencies, such as a pandemic. And in specific settings, such as here in Germany, for example, we are also describing the need for pandemic preparedness from a palliative care perspective, saying that there should be special regulations. Just one easy example, when hospitals and nursing homes are locked down in the pandemic, patients are dying alone without seeing their family members. We had cases where the family for about 4 weeks was not able to see their sick family member in hospital until he died alone. in an intensive care unit. And that's absolutely not necessary. You can prevent that by clarifying that isolation measures are not valid for dying patients and that family members should be allowed to see dying patients, even in intensive care units, even in a pandemic, provided you have adequate protective equipment.
Dr. Lukas Radbruch, Chair of the Board of Directors of the International Association for Hospice and Palliative Care, thank you for talking to Al Jazeera.
Thank you very much.